Hello, I'm Debbie Dobbs, and I'm going to give you a presentation this afternoon on quality drivers in healthcare. The learning objectives will be at the end of the conclusion. The participant will be able to describe the history of quality in healthcare in the United States, discuss the primary quality focus metrics and healthcare outcomes, describe how primary quality metrics influence healthcare leaders and nurse leaders to improve quality, and finally, to evaluate the effect of magnet status on quality initiatives. Quality actually began with Florence Nightingale when, in the Crimean War, she made the argument that hand washing improved the outcomes of her patients. She kept meticulous notes and research and was able to prove that to her constituents. We had the establishment of the Joint Commission in 1951, in which they talked about the rubric of defined minimum quality standards. Medicare and Medicaid was established in the 1965s in 1965, and it had a great deal of quality metrics. And then we had the IOM established in 1970, which we all know has launched many, many metrics and initiatives based on evaluating, informing, and increasing quality care. In 1989, AHRQ, or the currently known as the Agency for Healthcare Research and Quality, was established by the federal government as the Agency for Healthcare Policy and Research. In 2016, we had the Core Quality Measures Collaborative that came together with the CMS because they realized that providers were having to provide data to many different places. They were having to give it in different ways. So the CMS came together and got a group together made up of representatives from CMS, the Medicare and Medicaid managed care plans, their providers, insurance companies, purchasers, people who bought insurance, physicians, and other organizations, and then patients and families who were together, and they came up with some core measures that everybody would agree to work on. The purpose was to establish the alignment of core measures and these are pretty much written out as a goal, promotion of measurement that's evidence-based and generates information for quality improvement, consumer and which of course is patients and families decision making, value-based payment and purchasing to increase the quality or getting value for what they get, reduction in the variability in the measure selection so that everybody knows what they're having to report and everybody is reporting the same thing, and then decrease provider collection burden and cost so that they're not having to do as many different types and they're not taking them lots of money just to produce these data. They went together with the National Quality Strategy, which is a part of AHRQ, and it aligns very carefully with the three aims. This I copied and pasted exactly from their overview of CMS. The three aims are better care, healthier people, healthier communities, and smarter spending. They had 6 priorities that they have. Make care safer by reducing harm, strengthen person and family engagement and engage them as partners in their care, provide effective communication and coordination, promote effective prevention and treatment of chronic disease, and that's kind of where we get population health, working with communities to promote the best practices of healthy living, again, preventative health, and then making healthcare affordable. They came together and decided that they were going to have 7 core measures that these measurements are coming from. The first of which is accountable care organizations, which are the safety culture, patient-centered medical homes, and primary care. And this is where we're getting, again, in population health, where chronic diseases such as cardiac disease, diabetes are all gathered by one and their care is coordinated throughout their lifetime. They also looked at cardiology, gastroenterology, HIV and hepatitis C, medical oncology, OB, and orthopedics. And as you did all this and you read this core measures, you begin to think about what makes the difference and the influence for change. Well, in our field, and as in any field, money talks. So reimbursement is a huge part of what is going on, because we know that if you paid on your performance, then your performance is going to be better. This particular one talked about reducing your payments when there's high readmission rates for selective high cost or high volume procedures such as heart attacks, congestive failure, pneumonia, COPD, and joint replacements, as well as CABG. There was a hospital value-based purchasing program, which is there is a performance on each as reimbursement is based on your performance on each measure compared to all hospitals, or the degree of improvement of your own performance compared to a prior baseline. And then, of course, we're all familiar with the HAC reduction program, or the hospital acquired conditions. And this is, they cut your payments if you're ranked in the worst performing quartile in a subsection on either one of the HACs, or if your reduction is decreased if your total score is above 75th percentile of their total HAC score. Cost at what risk to quality? I took a situation that actually happened in my hospital in the last week, which just kind of brought to mind this question. And we're having a tough budget year at our hospital, and so we're having to do a lot of very careful things with our staffing. We're decreasing the staffing costs by taking away your premium pays. There's been an elimination of on-call shifts, with the exception of those who have to have it. It's pre-scheduled. And then a reduction of the risk of premium pay, such as PRN staff who are paid at a higher rate. We had last week, the inpatient medical unit was short, and so they also had a PICU nurse who was floated down to come to that unit about at 7 o'clock. At 3 o'clock, the intermediate care step-down unit sat down, discharged enough patients that they were able to send to decrease their numbers. So what they did, or they decided, no, I'm sorry, it was the inpatient medical unit who decreased their numbers, and so they didn't need as many people. The inpatient surgery unit had a PRN who has a certain skill mix. And at 3 o'clock, they canceled the PRN and sent them home. The nursing coordinator did this, and then sent the inpatient medical unit, who is not as highly qualified as some of the others, to the inpatient surgery unit, and left the PICU RN on the second floor. Quality in care, I think at this point, number one, you had a nurse who did not have as much experience caring for these postoperative patients, and as even the PICU nurse. And then, of course, the PRN was sent home. The inpatient, so there were two sets of patients, one on the second floor on the inpatient medical unit and one on the inpatient surgical unit, that had about 2 caregivers for the whole time. Quality at what cost? This actually happened in my hospital again. Actual wound. We have a wound patient who was ready to be discharged, and the wound products that they were using in the hospital were very expensive, and about $2,000. They were not covered by the patient's insurance, so the wound nurse had given the patient enough products to last a month for about $2,000. The hospital's not reimbursed for this cost because it was not done while the patient was hospitalized. Therefore, the hospital lost $2,000. Quality, yes, but a significant cost to the hospital. The Malcolm Baldrige National Quality Award is an award established by the U.S. Congress in 1987 to raise awareness of quality management and recognize U.S. companies that have implemented successful quality management systems. They are given in 6 categories: manufacturing, service, small businesses, education, healthcare, and nonprofit. They have several leadership criteria. Criteria for performance excellence and leadership strategy, customers, measurements, analysis and knowledge management, workforce, how the operations of the unit goes, and then the results. How are they able to give all that? It's a very prestigious award that's given annually, and it's awarded by the President of the United States. I was not familiar with this award. I'd read about it or heard about it, but I was not familiar with it until this presentation. It was very interesting. Magnet is something that we're all familiar with. The Magnet Recognition Program, it's DECIDE that it recognizes healthcare organizations for quality patient care, nursing excellence, and innovations in professional nursing practice. It is supposed to be, the award is that with research that people who are a magnet hospital is able to maintain or draw patients like a magnet to the hospital to keep them there. It advances 3 goals within the healthcare: promote quality in a setting that promotes professional practice. It identifies excellence in the delivery of nursing services, and it disseminates best practices in nursing services. In my opinion, the effects of either award does not guarantee quality. Just because you have the award or you win the award, it doesn't necessarily mean that you have it. But what it does do is provide an emphasis on quality improvement and encourages a culture of collaboration and safety. It does improve, Magnet improves the work environment for nursing, and there's been research done that says that it improves patient safety and quality, decreases mortality rates, pressure injuries, and increases patient satisfaction. My experience has been in the hospital in which I work is that there is a major focus on quality and a safety culture and we're not a magnet hospital, nor have we applied for such. For conclusion, quality has been a part of healthcare since the time of Nightingale. We have lots of regulatory and legal factions that has driven quality to the forefront of healthcare, as well as through the ACA. Reimbursement can be affected by quality outcomes regardless of your payer, and that quality improvement culture is often the result of such awards such as the Baldrige and the Magnet Recognition Program. These are the references that I have used for this presentation. Thank you, and I hope that you have enjoyed and have learned something from this.